All right, this is our lecture on arthrology. Arthrology is the study of joints. Joints are also called articulations, and articulations are junctions between two or more bones or rigid parts of the skeleton. Now, there are two ways to classify joints. The first is anatomical, and in anatomical joints we look at the structure or composition, what the joint is made of. All joints are made of connective tissue. So what we need to see is it fibrous connective tissue, is it cartilage, or is it a combination of these called a synovial joint? Next, we have the physiological classification of joints. This is based upon the function, or how much they move. The first of these is a synarthrosis, which has no movement. The second is an amphiarthrosis, which allows slight movement. And the third is a diarthrosis, which is freely movable. The first anatomical classification to discuss are fibrous joints. Now, fibrous joints are held together by what's called a fibrous connective tissue. And fibrous connective tissue appears in either ligaments or membranes, and the amount of movement here depends upon the length of the fibers. There are two distinct types of fibrous joints. The first is a suture. Now, a suture is going to be between the bones of the skull. Sutures start out as a flat membrane. We'll see this when we do bone formation. And they slowly are replaced by bone and shorten, coming together to make this tight joint right here. Now, the second kind of fibrous joint is a syndesmosis. The plural is syndesmoses. And syndesmoses are ligaments. These are ligaments anywhere in the body. So you may have heard in the knee of what is called the ACL, which is the anterior cruciate ligament, or the MCL, which is the medial collateral ligament. Both of these are syndesmoses. They are ligaments. Now, a specific type of syndesmosis or ligament, one of these is the interosseous membrane, which we see here. This is between the radius and ulna in the forearm, or between the tibia and fibula in the leg. This is a flexible membrane that allows some movement there. The next special ligament we're talking about is the gomphosis. Now, the gomphosis is also called the dentoalveolar syndesmosis. This is where the tooth is held in the socket, either in the maxilla or mandible. And this is a series of little tiny ligaments called periodontal ligaments, and these hold the tooth in place. You might think this is a synarthrotic joint, but it's actually amphiarthrotic. If it becomes too loose, it's pathological and it means you're losing the tooth. However, in a normal, healthy mouth, the tooth has to have a little bit of give to let us know the bite force we're using. So our fibrous joints are sutures and syndesmoses. Special kinds of syndesmoses or ligaments are the interosseal membrane and the gomphosis. Second anatomical classification are cartilaginous joints. Cartilaginous joints are going to be held together either with hyaline cartilage or fibrocartilage. If it's hyaline cartilage, we call it a primary cartilaginous joint. This symbol here means primary. If it's if it's fibrocartilage, it's a secondary cartilaginous joint. Now, going back to our primary cartilaginous, these are called synchondroses. There are two different types. There's a primary synchondrosis and a secondary synchondrosis, and here's the difference. They're both made of hyaline cartilage, but a primary synchondrosis becomes bone. We see this in the growth plate of a long bone. It's cartilage while you're growing. When you finish growing, this turns into bone. The second kind is a secondary synchondrosis, and these remain cartilage or remain synchondroses. We see these in the cartilage of the rib cage and in the articular cartilage covering joint surfaces. Now, in fibrocartilage or secondary cartilaginous joints, we call these symphyses. And you've seen these in the pubic symphysis and one was called the IVD, which is the intervertebral disc. And we typically shorten it here as IVD. Now, These remain cartilage throughout life. So our second category is cartilaginous joints. We have primary and secondary. Primary cartilaginous joints are made of hyaline cartilage. They either become bone, as a primary synchondrosis, or they remain cartilage as a secondary synchondrosis. Then our other cartilaginous are the secondary cartilaginous joints. They're made of fibrocartilage and they remain cartilage. And these are the IVD and pubic symphysis. The third category of anatomical classification is the synovial joint. Now, synovial joints are important because they're the most complex form of joint. Their key characteristic is an articular capsule. Interestingly, this is a fibrous connective tissue, and it forms the outer layer. So here. And then inside, it forms a joint cavity, which actually is a potential space. There's not a lot of room. This is exaggerated. But the joint cavity has a synovial membrane in it, and this is the inner layer. Now, the synovial membrane is unique. Most wet membranes in the body are epithelial. This one happens to be connective tissue, and it produces a fluid conveniently called synovial fluid. Now, also within this joint cavity, we have an articular cartilage, which is here. And articular cartilage is hyaline. So we can already tell that a synovial joint is a combination of a fibrous portion and a cartilaginous portion. It has a cavity in it, and it's a complex joint with a fluid filling the inside. Now, the outer covering of a bone is called the periosteum, and the periosteum blends in with that joint capsule, the fibrous part. It does not cover the joint surfaces because, again, the joint surfaces are covered by articular cartilage, hyaline cartilage. Synovial joints, again, are complex. They're going to have accessory structures with them. You're going to see supporting ligaments or syndesmoses. If they're extrinsic, then they're going to be outside the entire joint, so they would connect like this. If they're intrinsic, then they're going to be continuous with the joint capsule, so they would actually be involved in the joint capsule. We'll see examples of both of these. Otherwise, we have extracapsular and intracapsular. In some joints, we have ligaments outside the capsule. For example, in the knee, we have the MCL. And in the knee, we also have the ACL, which is inside the joint capsule. So extracapsular, outside supporting, intracapsular, inside supporting. Along with those accessory structures, we also have articular discs and menisci. These are going to be cartilaginous structures that build up the joint surface. We pad the joints with fat pads, with bursa that are just little pillows made of fibrous connective tissue and lined with synovial membrane and filled with synovial fluid. And then we're going to lubricate the sheaths by wrapping a kind of a bursa-like structure called a tendon sheath or tenosynovium around the tendons. Synovial joints, because they are so complex, have a rich blood supply. The arteries and veins will go into the capsule. However, they don't supply the articular cartilage directly. Articular cartilage, like all cartilages, has a weak blood supply. It gets most all of its nutrients and materials and gets rid of waste through diffusion. Now, our last concept for this slide is that nerves associated with the muscles moving the joint are the same as the nerves that innervate the joint. And there's a rule called the Hilton law that says nerves supplying a joint capsule also supply the muscles that move it and the skin covering the attachment. This is a way for you to keep in touch with how much you're moving the joint so that you're not moving it outside its normal range, and it gives you an idea of where the joint and body part are in space and time. This is a part of proprioception. So if synovial joints are the most complex, then we have different ways of describing them. There are 3 joints that are considered uniaxial. That means they basically move in one direction. So they're either going to flex or extend, or they're going to pivot around a joint, or they're going to slide against each other. The first of these is the planar joint. And we see the plane here, and it is at the end of the clavicle, and it's between the bones of the wrist and the foot. So we see. All right, our next joint is called a ginglymus joint. And the ginglymus joint is also called a hinge. And our primary hinge is at the elbow. We also see it in the fingers, and it's going to allow flexion and extension. Our third joint is the pivot or rotary. The pivot joint we're going to see here in the forearm that allows pronation and supination. We also see it in the neck that allows you to shake your head no. Then we move on to a group of joints that are biaxial. And biaxial means they can move in two directions. These are the condyloid and ellipsoid, or the saddle and cellate. Now, the difference between these is that the condyloid has a surface this way and a matching surface. The saddle joint has a surface this way and a surface going across it, like someone sitting in a saddle. So you have the person sitting. There we go. All right, cute enough. In a condyloid joint, we're going to see movement in two directions. So we come over here and we see our condyloid, and it allows flexion and extension. It also allows abduction and adduction, and sometimes a modified version of circumduction. So we see here that I can both spread the fingers wide and I can also bend them at the knuckle. The saddle joint, there's only a few of these in the body, and the primary one we talk about is where the thumb, the metacarpal, meets the carpal. And we'll discuss that in more detail with the appendicular skeleton. But here we see in saddle joints, it's going to allow movement in two different planes. And interestingly, this particular one at the thumb also allows circumduction. How's that? All right, our last joint is going to be the ball and socket, also called spheroidal. And you do need to know both names I've listed for the joints. All right, spheroidal joints or ball and socket joints are multi-axial. This means they're going to allow movement in multiple directions. So the ball and socket is the hip joint, and it allows you to flex, extend, abduct, adduct, rotate medially and laterally, so it's going to go in at least 3 different directions, and it can circumduct. All right, so we see that there are 6 different types of synovial joints. This is all based upon structure and movement, because it's the structure of the bone that helps determine how it moves. So here I've started a chart that shows on the top our anatomical organization of muscles, and here on the side our functional representation or classification of muscles. And what I've done is put in examples of fibrous joints that are synarthrotic, cartilaginous joints that are synarthrotic, and there are no synovial joints that are synarthrotic. You don't go to the effort of making a synovial joint with a joint capsule and articular cartilage and a membrane and a fluid and all the accessory structures just to not move it. On our amphiarthrotic fibrous, we see fontanelles and gomphoses. In the cartilaginous amphiarthrotic, we see the pubic symphysis, IVD, and costochondral. And once again, we see only one amphiarthrotic synovial joint, and this one is a real interesting joint. We'll discuss it with the appendicular. It's called the sacroiliac joint or SI joint, and you will find that this is one of the bread and butter joints of a chiropractor. Our last category is diarthrotic, the freely moving. And we see there are no fibrous joints that are freely moving. We see there are no cartilaginous joints that are free moving. And we see that all of our synovial joints, except this one, are free moving. So, in our sutures and gomphoses, these hold tightly together. Gomphoses also, remember, allow some movement, so they are actually considered primarily amphiarthrotic. That's why I did not capitalize this one. We see the cartilaginous synarthrotic joints, the epiphyseal plate, sternum, and the interpelvic joints. We see our cartilaginous joints that are amphiarthrotic. And again, our synovial joints are all diarthrotic with the exception of one. Don't panic on this chart. We're going to fill it out as we go through the parts of the skeleton and its joints. Okay, for the most part, joints are named for the bones they connect. This makes it really, really easy. So we see here between the temporal bone and the mandible, called the temporomandibular joint. Now, you're familiar with this one because it's where your jaw, the lower jaw, moves. This is why we say TMJ when somebody says, oh, I have TMJ. Yeah, we all do. What you're thinking of is temporomandibular joint syndrome. All right, getting off my high horse. The atlantoaxial is between, or atlanto-occipital is between C1 and the occiput. The atlantoaxial is between C1, C2, between vertebrae, between the vertebra and the rib, between the sternum and the rib cartilage, between the lumbar vertebrae and the sacrum. By the way, this is another good bread and butter part of your new profession. The sternoclavicular joint between the sternum and the clavicle. The acromioclavicular between the acromion process and clavicle. These guys make up your shoulder. The glenohumeral is another part of the shoulder. This is that ball and socket joint. You have the radiohumeral, humeral ulnar that make up the elbow. You have the radial ulnar and that makes up the pivot. You have the radiocarpal, which allows your wrist, specifically the scapholradial. You have joints between your carpals and tarsals, between the metacarpal and carpal, or the metatarso and tarsal, between your metacarpal and phalanges, that's your first knuckle, metatarsophalangeal. You have them between the phalanges of your fingers. By the way, the singular of phalanges is phalanx. We'll see them between the sacrum and the ilium, that's your sacroiliac joint. You see the hip joint, also called coxal or acetabulofemoral. You see the tibiofibular. You see the talocrural. You'll see facial sutures that are named. We'll go through all of these. The one you may not be familiar with at all in this one is the talocrural. This is your ankle. Now, one notable exception to this naming is the cranial sutures, and that's in lab this week. So your coronal, your sagittal, the sutures surrounding your brain have special names and are not named for the bones they connect. There are multiple things that can affect how much you can move at a synovial joint. We call this the range of motion. The first factor we're going to talk about is the shape and structure of the bones and cartilage. So we see there are different bony landmarks that allow or inhibit movement. Because the shoulder is a ball and socket joint and it actually has cartilage built in to help protect the movement, then we know this is a multi-axial joint capable of flexion, extension, abduction, adduction, external and internal rotation. By the same example, the elbow we're going to see has a specific trough and then bony edges that prevent it from doing anything more than flexion, extension. Our next thing is the strength and tension of ligaments. If you've ever been told you're double jointed or you know someone who is, it doesn't actually mean they have an extra joint there. It means that their ligaments are loose, and this allows the joint to move outside of the normal range of motion that we would expect. By the same token, if the ligaments are too tight, you'll have a reduced range of motion. This and the next part, the arrangement and tension of muscles, is part of the reason you have a loss of movement in joints as you get older, because these tendons and ligaments can tighten up. So if you're able to touch your toes or put your hands on the floor, your hamstrings are probably stretched out and loose. If you can, they may be too tight. So the muscle arrangement and the tension. We're going to see that tendons go through specific bone structures to act as pulleys, and they're going to determine which way we can pull a body part to move it. Our next category is one of my favorites. It's called the apposition of soft parts. Most of the time when we think of this, we think about people who have gained weight. The more fat you have like around your midsection or around a limb, the less you can move it within a range of motion, so you can actually restrict that. But what we forget is that people who build up their muscles can also restrict range of motion because they have muscles in the way of what they're moving. You also need to remember that tumors or other growths in the body can cause a blockage of the ability to move and therefore inhibit movement. So any soft part, that is anything that's not a bone or a ligament, can cause a change in the range of motion. Another adage that's true is disuse. If you don't use it, you lose it. If a joint is held too long without motion, it can fuse together, which is called an ankylosis. Now, sometimes they do that surgically, sometimes it happens because of genetics, sometimes it's because of trauma. That's one of the reasons why when they cast broken bones now, they try to get you to move it, or at least put weight on it while it's healing to help promote movement and stop the fusion of bones and joints. Our last category is aging. As you age, from newborn on, you lose flexibility, especially because your movement can slow down. You also lose muscle mass and strength, so you may not be able to move the way you did before. One key thing I want you to keep in mind is that aging begins at conception, not just the people you think are older than you. From the time you're conceived all the way until the time you die, you go through different age ranges and you have certain expectations in the formation of the bone and the movement of the bone and the ligaments and all the associated parts. So please remember these 6 different factors affecting range of motion. And don't forget to start. Aging is from conception on. In the following slides, I want to get you familiar with terms of movement so that we can discuss how joints move when they move. Our first term of movement occurs on the sagittal plane. Now remember that almost all of these are in relation to the anatomical position. In the sagittal plane, we're moving primarily anterior or posterior. So we see flexion is bending or decreasing an angle. This is almost always anteriorly for anything above the knee. Extension is a straightening or increasing the angle between bones, and only the knee is anterior in this movement. There are 2 special kinds of movement in the sagittal plane. These are dorsiflexion and plantar flexion of the ankle. The ankle is in extension in anatomical position, so we either have to raise the toes up, which is dorsiflexion, or push the toes down, which is plantar flexion. Now, we define hyperextension as an extension of a limb or body part beyond the normal limit. Our next category is the frontal plane. In these we go side to side. We have lateral flexion, which you can do of the trunk and the neck. There is also abduction and adduction. Now, lateral flexion is sometimes called abduction and adduction of the trunk. So, ab and add. Typically, though, we use abduction and adduction to talk about moving a limb away from the midline or towards the midline, and away from the midline or towards the midline. Our next categories of movement are special movements. We can abduct the digits, and in these we spread them apart, so we see here, and then we can add them back together. We can also do a special movement of the thumb called opposition and reposition, and an opposition and reposition. Opposition means we can take the pad of the thumb and touch it to each of the other 4 fingers. In reposition, we just move it back to neutral. Oh, one final point I want to make here is that abduction of the thumb is not out to the side, it's out to the front. So we move the thumb towards the front, out towards the wrist as we move the fingers apart. Our next categories of movement, again, are kind of specialty movements. We see circumduction, which is a circular movement. We can do this with the shoulder and hip joints, ball and socket. We can also do this with the thumb. Circumduction involves being able to flex, abduct, extend, and adduct in that sequence. The next one we see is rotation. Now, rotation is interesting to kind of define. We can rotate the neck, we can rotate the whole trunk, we can rotate the upper limb and lower limb at the shoulder or hip. If you bend your elbow and then rotate your fist in towards your stomach, this is called internal rotation. If you flex the elbow and then move the hand out to the side, this is called external rotation. We also call them medial and lateral rotation. This is a movement actually happening at the shoulder. By the same token, if you rotate your feet out so that you're standing kind of like a duck, then this is lateral rotation of the feet. If you move them in, so you're standing pigeon-toed, this is medial rotation of the feet, and this actually occurs at the hip joint. Our next category is eversion and inversion. Eversion and inversion are special movements of the foot at the ankle. In eversion, you push the sole of the foot on the medial arch downwards. As you lift the outer edge, it's pushing the sole of the foot out to the side. In inversion, you bring the sole of the foot inwards while basically resting your body mass on the outer edge under your pinky. Our final terms of movement. We can protrude and retrude. When we protrude, we push something out to the front. We can do this with our mandible as our chin, our lips, our tongue. When we pull them back beyond neutral, then we're retrusing them. Another term similar to this is protraction and retraction. We typically use this for the scapula. We protract when we pull the scapula apart from each other, here, and we retract it when we pull them back together, here. So we push the shoulder forward in protraction, we bring the shoulder back in retraction. Our final group here is elevation and depression. In elevation and depression, we do this typically with our shoulders, our upper eyelid, the tongue, and the mandible. With the mandible, we close our mouth. With the tongue, we push it against the roof of our mouth. We open the upper eyelid, and we can raise the shoulders up, as in, I don't know. In depression, we lower the shoulders, or we lower the eyelid, closing our eye, or we take our tongue away from the roof of the mouth and back into the lower oral cavity, or we depress the mandible and open the mouth. All right, that's the end of this lecture. If you have any questions, just let me know.